Well, welcome everybody to our first North Carolina Pre-Hospital Blood Coalition meeting by Zoom. I appreciate you giving us your time today. This is being recorded and will be posted up on a YouTube channel, and we'll let you know where it is. Probably next week, we'll do a follow-up with everyone. We've got a quick program for you. Want to leave a lot of time for questions and answers. And if you have a question you want to go ahead and put in the chat, then one of our folks can look and be prepared. Or you can wait till the end and then a mad rush to see who can talk over who. So for now, you need to know this is being recorded. I'd like you to stay muted if possible to make sure the recording is clean as possible. We're handing off back and forth shared screen for the presentations, and we'll go ahead and get started. I'm going to hand you over to Jeff Henshaw.
All right. Thanks, Joseph. Thanks for everyone's time this afternoon. As you're going to find when we start this, that this is not a one and done for us. What we would like to do with this is a series of these webinars over the next few months to the year to kind of help set the standard for what is this thing that is emerging out to us, these pre-hospital blood programs. So we thank you for attending today. There are people who are giving blood now. There are people who are considering giving blood. We have administrators, we have vendors, we have other states represented, lots of different things here today. So I'm going to try to kick things off and get us going here this afternoon. So a little bit about us. This Pre-Hospital Blood Coalition, I will consider myself a plank owner. If you are in the Navy, you will know that plank owners are christened when they are members of the crew when the ship gets commissioned and put to sea. So there's a core group of us that you'll hear from today that will explain their roles in this coalition and things. Mine is multifaceted. I'm the lead PA in the emergency department at Wake Forest Baptist Medical Center, Division of Atrium Health. Again, working at our trauma center here, as well as at a community shop at Wilkes Medical Center in Wilkesboro, North Carolina. The reason for the blood is the fact I am Deputy Medical Director of Wilkes County EMS. We were the 5th EMS agency in North Carolina to come on board with the pre-hospital program. And you'll hear more about our program going on in another venue later this year or even next year when we have our additional webinars that we'll have for you available. Today we'll highlight a couple of different programs. My friends from Surrey County, I live in Yadkin, so they're just across the river. We'll tell their great story, and then David with his story from Cumberland County as well. So let's start this off, and let's start with some slides. Let's talk about the fact that, so you really want a pre-hospital blood program. So you have to ask yourself the question, why? And what is our rationale for doing this in today's world? Next slide. And Joseph, if you just want to every couple of seconds, go ahead and beep in the others, that is perfect. So let's review the facts. Let's talk about Joe Friday and Bill Gannon on Dragnet and what are the facts that are facing us in today's world. We know that exsanguination is deadly, whether that be from a medical cause or a traumatic cause. We know that that's an issue that we have to deal with. We also know that in today's world, many trauma deaths can be prevented. So we have issues that abound when it comes to traumatic injuries and blood loss. We know that blood loss is a health crisis in the United States and that trauma care is inequitable. Folks, we are so blessed in the state of North Carolina to have as many hospitals and trauma centers as we do, because you go out west and there are states that have only one trauma center for the entire geographic area of their commonwealth or state. In fact, there are places and there are issues that abound in the United States where people live more than an hour away from a trauma center. And as such, when that happens, their chance of dying from a traumatic event goes up to over 50%. So as you go forward, again, what are the issues? What are the things that we deal with in today's world? Well, here's a couple of other facts. Those that are paramedics in the room know that we are under-equipped to treat major blood loss. We know that we can put on a tourniquet, try to take care of junctional hemorrhage, but right now we have crystalloids to re-infuse with. We know that blood transfusions often come too late for the patients that we are seeing. So we know that getting blood to the patient is an important treatment for them. We know that right now pre-hospital blood largely remains unavailable to our EMS colleagues. We know that as of September 1st, There are less than 175 programs in the United States, pre-hospital wise, that give blood. So we are truly, if you are on this webinar, you're in a unique position to be able to offer something. And for those that are considering this program, make a huge change, a big outcome in your patient's changes should there be exsanguination from either medical or traumatic event. So JZ, there should be one more bullet point on that slide, then we can go to the next one. Yes, the most important one. We know that blood programs can and do save lives. There'll be some case studies from our colleagues over the next few minutes that outline this particular event. Next slide. So why does blood become important? This is a position statement from the American College of Surgeons Committee on Trauma released earlier this year, noting the fact that what is the standard of care for us to provide care to a trauma patient in the United States. Next slide. On that slide, you'll notice right in the middle, it talks about a recommendation. Next slide, Joseph, and we'll highlight this recommendation that patients with the sign of hemorrhagic shock should receive pre-hospital blood products whenever available. So this is a national accredited agency guiding emergency medical care for us, and their recommendation is if this is available, the patient needs to have it. So where do we go from here, and how do we change things, and how do we implement these types of programs? Next slide. So let's talk about check boxes. One of the things that we're going to host for you over the next few months, and as we progress with things, is a repository of forms, protocols, policies for you to be able to take and use this as a foundation for you to make your programs better. So let's look at a basic avenue or a basic look at some check boxes that if you're in that program and you want to consider a blood program for your EMS agency, where do we stand right now? First thing that I would challenge you with, you need to be looking at your numbers. What are the patients you're transporting? How many medical patients? How many trauma patients? Let's look at vital signs and outcomes. Are you tracking patients who are hypotensive and tachycardic? Are you tracking end-tidal CO2? And one of the most important things that will be brought out in future lectures is the use of the shock index in resuscitation. Next bullet point. And JZ, you can go ahead and add these in as well as you need. So I want to say buy-in and convince, but it may not necessarily be convince. It's the fact of who is going to be your champion when you start a blood program. So one of the things that I'll challenge you with is, who is that champion? Is it coming from administration? Is it the medical director? Is it your crew? Who's going to be the champion? And then flip that coin over and say, who is the person that we have to get buy-in or convince to make this happen? Because this is going to have cost associated with it. So the things to think about is administration on board. You have a medical director proactive, wanting to have this program available if it's justified by the numbers. One of the people that you'll get to meet very quickly in this, if you decide to go down this pathway, is your local blood bank, or who you're going to get your blood through. Those will be folks that you'll have to interface with, and also your crews. Is this something in today's world of burnt out paramedics who run multiple calls a shift, who may not see the engagement that they have in the past? Is this something for them? Now then, let's talk about the financial part of this, the startup cost. Blood has to be stored at a particular temperature. That can range from a Credo cooler ranging about $1,000 up to a military grade cooler that costs $11,000. You have to make a decision on what you're going to use with that. I'll use a statement from one of my mentors early in my career: cold doesn't clot. So if you're going to be giving blood, I would highly encourage you to consider some form of warmer for your blood products that you're going to be given. Are you going to drip it or pressure infuse it? Again, more equipment that you have to consider, along with medications, again, blood tubing, and other things associated with this. Let's look at the next bullet point. Can you even get blood? Do you have a trauma center available that can supply it? Are you going to have to buy it from Blood Connection or the Blood Source or the American Red Cross? Again, anywhere from $450 to $600 per unit, depending on what we're dealing with. Again, lots of cost, but a good return on the investment. The other thing that we have to think about in regards to cost is time. You're going to have to train people to do this. This takes a program that has an immense amount of quality management and quality improvement. The administration of blood is FDA regulated. If you think narcotics are one thing, we're going to take it to the next level with blood administration. and documentation, much less the ongoing cost of the program. What happens when people transition away from agency? And lo and behold, you have to train other people to go along with this. Next slide. So what about Chicken Little? What if suddenly the sky decides to fall? And what are the bad things that could potentially happen when we talk about blood administration? When we started our program at Wilkes EMS, these were the 4 bullet points that I came up with in my prioritized list of when the sky decided to fall and I was Chicken Little. Daily checks and product swap out. It is an immense amount of time that has to be spent, only just a few minutes a day, just to check that thermometer, check some things on the refrigerator. But it's something that, again, most paramedics aren't used to dealing with, so that's going to be a hiccup that's potential. Documentation. If you're, depending on what medical record you use, there's going to be additional documentation, and that documentation has to be forwarded to the blood bank or the vendor which you got your blood. How do you restock the blood? What are the issues associated with that? And notice, last but not least, my least prioritized hiccup was the actual administration of the product. The medic can do this. That's not going to be an issue. It's the other administrative things that I think become important in the end. With that being said, one last slide that we'll talk about right quick. That's all right. Let's summarize things, and I'll keep it under my, I'm right at 10 minutes and 12 seconds, so I'm going to be just a little bit over. This is truly, ladies and gentlemen, a business investment. We're talking about cost that is with this, with a return on your investment as well. When we talk about implementation timeline, you're looking at probably 8 months as an average to be able to start your program. So if you started January 1st, you're probably looking at August before you're going to come online with this. So again, this is not something that happens quickly. Copy someone's program. It is perfectly fine to copy someone else's out there. Do not feel like you have to invent the wheel from the beginning. You're going to be in contact with multiple stakeholders, many of which you've never interfaced with before. So that's something that'll be new for most EMS agencies. The blood supply and the vendor issues that come along with this, with equipment that we've never had to use before. But I'll leave you with one simple word. If you choose to do this, it will be impactful in many ways that you didn't necessarily anticipate when you started the program. With that in mind, Joseph, I am done with my section, and I'll toss it back to you.
All right. And we're going to head over to Surrey County, and Justin and company, they're going to share their screen. They'll be coming up shortly.
Oh man, second on there. All right. Okay. Well, good afternoon, everyone. My name is Justin Darrell. I am the training officer of Surrey County Emergency Services, and alongside me today is our chief, Mr. Eric Southern, and we're going to talk a little bit about our background, where we came from, where we're going, and what's worked and what not worked. JD, I just want to confirm you can see everything okay there, sir?
Yeah, you've got to duplicate your screen. We're seeing the preview as well on this end. There you go.
Yeah, swap them right there.
There we go.
That fix it?
There, perfect.
Awesome. So just to talk a little bit about this slide right here means a lot. It takes a team, where you're coming from, where you're going to go, the ones that are involved, those stakeholders that Mr. Henshaw just talked about. You know, we as a pre-hospital had to get hospitals on board with our plan and join forces to make this happen. And at the end of the day, it's all about improving patient outcomes. And we're going to talk about one scenario of many that we've had in success stories when it comes to field of blood administration. So again, thank you all. I think you all are here for the right reasons, to improve patient outcomes, to save lives and make a difference. And at the end of the day, that's what it's all about. But do remember, it takes a team. It takes us working together. We've made many of mistakes along the way, but that's how we learn and how we improve and how we get better. So thank you all for being here, for your time. And we're here to help in any way, shape, form, or fashion that we can. So we're going to go to the next slide, and we'll let our chief discuss here our progression along the way and the steps and how we got to where we come from.
Well, good afternoon, everybody. This is Eric Southern. Just want to kind of give you a little bit of background and how our blood program got started. And as you can see on the slide, November 2016, kind of just started with an idea. We started working with Northern Regional Hospital, and they were gracious enough to let us pick up blood and take it to the scene. Mount Airy Police Department partnered with us, and I think about 2 weeks after we started that, we had our first call. Mount Airy Police had picked it up, run it to the scene, transported our patient on down to Atrium Health, Wake Forest Baptist, and had a positive outcome. And right after that, we had about 2 to 3 more calls, I believe. Seeing it was going to pick up, so we started looking at other ways. So the following year, we actually started carrying 2 units of blood with our supervisor, and a local business actually donated the money so we could buy our first cooler. Started out, that was going to be related to trauma calls. Had several calls with that. And as we've seen, we could start doing a little bit more. So we wanted to modify our protocols because we had GI bleeds, for instance, that we needed to administer blood. So within 2 years after that, we modified our protocols, started administering blood to those GI bleeds, and it really took off after that. In May of 2020, the hospital lab at Northern Regional began supplying us blood, and we ended up getting a second refrigerator for our other supervisor unit. And that way we were able to cover our entire county on both sides. Since then, like I said, the calls have picked up. We administered a lot of blood. It's been very successful. Our partnership with Northern Regional has been great. And there are times whenever they have to call us for blood because they're needing blood back in the hospital. But again, great communication, great partnership. It worked really well for us and for our citizens, and we have definitely made an impact with that. One of the things to note at the bottom of the slide was cost and availability of the whole blood. We are still utilizing packed red blood cells because of that. That's what we can get from Northern Regional. We talked about whole blood. We've had that conversation with them, but that right now is still in the works. So that's what we're carrying.
So how you're going to store your blood and whatever works for you, as Mr. Henshaw was talking about earlier, where you're going to put it, what cooler you're going to start with. Chief Southern went over how we started our first blood cooler. Top left image there is our main primary supervisor's vehicle. Middle center there on the bottom is the cooler itself that pulls the pull-out tray to get that blood out readily accessible. This only started on one vehicle, as we just discussed, and then we went to the secondary vehicle. Top right is our assistant supervisor vehicle, so they split the workload. Depending on where the call comes in the county, or depending on which unit responds, we try to get ahead of it. If it sounds like something that is going to need blood products, then we automatically, they'll self-dispatch themselves to the scene, or the unit calls for it as soon as possible, as soon as they see the need arises for that. So we did just start out with one blood cooler, and then we added the second one to the other half of the county, and they split the workload so it's more accessible to our citizens across the county. Running into one of our case studies, and we have many success stories. We pulled this call report here, reviewed it, just running through the straightforward facts of it. A traffic accident involving a motorcycle. They note copious amounts of blood volume in the roadway there. Even a layperson attempted to apply a tourniquet to this person. The assistant supervisor vehicle was self-dispatched to this, arrived on scene. We have our scene times there listed at the bottom and how quick we were able to get blood products on board. But I think the drive home point here is that patient presentation of, would this patient have made it? Would this patient have made it to that trauma center without blood being readily available out in the field? That initial blood pressure of 89 systolic, elevated heart rate, and then the blood pressure upon arrival at the hospital being 133 systolic. And I am fortunate enough that I was actually on the ambulances when this first came out before I moved into administration, and was able to administer blood out in the field and to see the results that are there, not only from that vital sign, but that patient assessment, the visual assessment of the patient when they're pale and they're cool. And, you see that, and you start administering blood and they start getting better. And out here in rural, Surrey County, we're transporting these patients to an hour plus to a trauma center, and it's making a difference in patient outcomes, and that's today saving lives. And that's what it's all about. So again, thank you all for having us. We have a lot more information, a lot more research that we have readily available. We look forward to collaborating as we move forward. But again, thank you all for your time. We look forward to working with you. JZ, thanks, sir.
Thank you, guys. All right, David, we're going to rack you up here.
Sounds great. So my name is Dave Grovedahl. I'm the chief at at Cumberland County EMS in Fayetteville, North Carolina. We're one of the urban centers in North Carolina, 75,000 call volume system. We are a hospital-based EMS 911, so we are just a little bit different than a lot of the systems in North Carolina. We have been a whole blood program for just about a year. I also have the distinct pleasure of having started several of the whole blood programs in North Carolina. So it's been great to see this expansion growing. I appreciate everybody being here. In Fayetteville, like a lot of urban centers, we utilize blood in our trauma program. One of the biggest arguments that I do here is in the urban setting, we can get to the hospital way before there's an opportunity for blood to be administered. And I just want to take a couple of minutes to point it out. The golden hour is no longer the golden hour. That EMS has evolved to a point. Blood absolutely in the formula for trauma definitely needs to be very high. I think it doesn't necessarily need to be said, but it needs to be said. Saline salt is salt water. Salt water needs to be used for pasta. It doesn't really have a place in trauma anymore, especially with the advent of whole blood. If you'll move along, Jay-Z, for me. So just a couple of journal articles. These are a little bit dated, but I do believe that it drives the message home to Journal of Trauma in 2012. By the time of arrival at the ED, 28% of trauma patients have very significant issues when it comes to trauma resuscitation. In EMS, we deliver patients that are under resuscitated in trauma just because we've never had the tools to be able to resuscitate patients adequately. We're delivering a patient that we've really not been able to do a whole lot with. And so we have changed this paradigm now with the advent of whole blood. If you'll change, Jay-Z. So once again, American Journal of Trauma, keep moving along. Time is our enemy, obviously, and EMS time is where we have the most impact. And so any opportunity that we can do to help resuscitate a patient, bring them to the hospital, resuscitated so that the next steps in the process can be completed without delay, then we're obviously going to improve the patient's outcomes. And I think Dr. Peel will beat on this topic a little bit further. Jay-Z, if you'll continue to move. So I think it's pretty much said that the median pre-hospital time is about 27 minutes. I know in a lot of urban centers, we're on and off scene in 10 minutes, but the patient never begins bleeding when the ambulance arrives. It's always prior. So when you're thinking about your times on scene and your times at patient contact, a lot of times with CPR, we talk about first medical contact. Well, in trauma, I would argue that we need to be talking about from the time of injury to the time of delivery at the hospital. And that's where EMS has the most availability here. Jay-Z? So if you think about it, a lot of times when even in this urban setting, if we have great time getting to the patient, if we're not dealing with the 5 o'clock rush hour, we're not dealing with the 8 o'clock rush hour, we're not dealing with construction issues all over the place, we're not dealing with congestion in areas, we still have to consider a lot of those times. And I bring up this auto pedestrian patient that not in our Fayetteville system, but in the previous system I had, a 26-year-old female that was hit in a parking lot by a speeding car. By the time the crew had a response time of about 10 minutes to the patient, and super quick, to the medic's credit, they recognized a very, very sick patient. She was already showing signs of shock from a very significant pelvic injury, and 10-minute response time, 10-minute on scene. A lot of times 10 minutes on scene is a gift if you're able to get on and off scene that quickly. And then a 10-minute transport to the hospital. And this is a very conservative number for argument's sake. A lot of times we have much longer time. You're already at 30 minutes. And so if you add the time that from the time that there was an injury to the time that the 911 call was made, response times, on scene times, transport to the hospital, offloading, getting into the trauma bay, moving the patient over, you're absolutely always at 30, 45, sometimes pushing more, even in an urban environment, unless it happens outside of the hospital. So vital signs on scene, patient's blood pressure was 50 over 30. There was really no palpable pulse. That the patient had. She had 140 heart rate. She had a GCS of 3. Patient was moved to the trauma center. And my favorite thing I love to hear from trauma surgeons is, had it not been for EMS, she would have been delivered dead. And I can't work with dead. So, I will tell you, in the rural setting, it is absolutely true. The super rural setting, this is where blood is super, super impactful. But in the urban setting as well, it absolutely, most certainly does make an impact. And so whole blood, yes, we need to consider it for those environments, but absolutely in the urban center too. So I appreciate your time. Hopefully we've made a great argument for urban and suburban, and I will now turn it over to the next.
Thank you, David. Just a reminder, if you have questions, you can go ahead and put them in the chat. So as we wrap up, we are going to open it up for folks to speak. But if you have a burning question or in-depth question we have to look up, go ahead and put it into the chat. We're now going to turn over to Dr. Mark Peel to talk about the research.
Hey, thanks, Joseph, and pleasure to be here. I'm Mark Peel. I'm a physician, pediatric intensive care physician, actually, at Wake Med, and one of the medical directors for Wake Med Mobile Critical Care, and got interested in this topic many years ago after the fairly prominent death of a child that we cared for, who I felt subsequently would have benefited from more effective resuscitation, both in the field and in our hands as soon as she arrived at the hospital. And so to make you aware of my conflict, I'm the inventor of a device that's used to give, a rapid infuser that's used to give blood rapidly, that many of the agencies that I'll tell you about are using, and some in North Carolina and nationally. Just be aware that I have a conflict there, but I'm going to try to present to you objective overview of the research here. Quickly, David, I agree with everything you said. One caveat is the avoidance of saline in every condition ever, and in particular with kids. We need to remember that hypotension is the single biggest risk factor for death in a pediatric trauma patient, the single biggest risk factor, and that a modest dose of saline, if that's all you have, 20 per kilo prior to arrival at the trauma center or as soon as arrival, is both safe and effective. So I agree with you that overuse of saline is a bad thing. We all want to be giving blood, but to those of you that don't yet carry it, be aware that especially in kids with severe trauma and hypotension, you can effectively use a modest dose in the beginning of their care. Joseph, go to the next slide. So I just want to start high level with the concept that minutes do matter in trauma care, and all the previous speakers have pointed this out. This study comes from UPMC up in Pennsylvania, where they looked at air medical, mostly treatment of pre-hospital trauma with hypotension, and showed in a combination of 2 studies they analyzed that every minute in delay of therapy results in increased mortality. And the therapy in this case was TXA and or blood transfusion. We haven't talked about TXA. Some agencies are carrying it, some are not. I'm a believer in it, but just believe that minutes do matter and delays cause harm. And so the question is that you all will struggle with, in thinking, you can go to the next one, Joseph, in thinking about, do we undergo the cost and complexity of implementing a pre-hospital blood program? Are there data to support its efficacy? Are lives saved through pre-hospital blood transfusion? We intuitively all believe it. The military data show it. Some of the air medical studies do show it with plasma and blood. But in the biggest study to date, and one of our panelists here is one of the authors, Dr. Schaefer, of this study, and the biggest study to date out of San Antonio, who's one of the pioneers of ground transport blood transfusion. They looked at a lot of patients there who got blood for severe trauma. They showed that those in whom blood was given were sicker at the scene, had a higher shock index, lower blood pressure. They did have vital sign improvement by the time they reached the hospital. They died less often in the ER, but they were not able to show a change in hospital mortality. And so does blood make a difference in people walking out of the hospital or not? In the next slide. And then a big randomized trial that should answer this question was conducted in Britain, and they randomized patients with shock and trauma to blood products. In their case, it was packed cells and freeze-dried plasma versus saline. And they showed, interestingly, that there was no difference in outcome. And I just want this study to be on your minds because people will point to it and say, see, pre-hospital blood doesn't work. What we have to keep in mind is the context and what they gave and how and when. And in this study, we don't have time to go into it now, but the total pre-hospital time was 90 minutes, 90 minutes. So 25 minutes to arrive on the scene, 25 minutes on the scene, and about another 30 in transport, during which the patient got that unit of pack cells. And so they basically did not effectively resuscitate the patients within the time they have, in my opinion. And we've written editorials on this to push back on it, but don't take this study to mean that blood doesn't work. Joseph. So what I'm going to share with you is the one of the agencies I've had the privilege of working with. It's New Orleans EMS, and keep in mind this is urban EMS with a high rate of penetrating trauma due to the epidemic of gun violence. So this may or may not be applicable in some of our rural settings in North Carolina. I think it probably still is in many cases, but certainly in our urban settings. I got to help analyze some of the data from that agency where they're giving 2 units of pack cells. They don't have whole blood yet either, and 2 grams of calcium and 2 grams of TXA for patients with penetrating trauma and hypotension. And they define that as systolic of 70 or a shock index over 1.2, which means a heart rate over systolic of about 1 to 1.2. And it's an awesome marker of shock. We should probably be incorporating it into our protocols for assessing septic and traumatic shock, obstetric hemorrhage, a lot of things. So basically anything over 1 to 1.2 indicates severe shock. And for those vitals, they're administering that package of care, packed cells, TXA, and calcium. And then we studied the patients who did not have an isolated TBI or gunshot wound to the head or arrested on the scene, and then evaluated the remainder of the patients for outcome. Next slide. And showed that if you look at the patients who got the blood, the advanced resuscitative care bundle, they had an initial scene shock index that's super high. That's pre-arrest, 1.4. That was resolved as both the folks in their anecdotes presented before. You see that vital signs, namely shock index, are improved on arrival to the trauma bay, almost to normal. About 0.7 or under is about normal. So they resolve their shock. Next slide. Fascinatingly, we found that the patients who ended up getting this blood transfusion in a short transport, they have 7-minute scene and about 9-minute transports, ended up not needing to be intubated anymore. So patients presumably got their resuscitation, improved their GCS, improved the management of their own airway and breathing, and that intervention of pre-hospital intubation, which itself can be deadly, could be deferred. And in some cases didn't need to be done at all. And so resuscitation may have prevented the need for intubation in these cases. And then next slide, they showed a reduction in mortality. So penetrating trauma with hypotension is a sick bunch of patients. Their average mortality, if you took out the scene arrests, was 25%. And that was reduced to 11 or 12% in the patients that got blood. This is about to be published. Should be out, I hope, in January, and will be the first study showing a mortality reduction for the implementation of a pre-hospital blood program in a ground EMS system. And so this is an important evidence that's worth knowing about, and we'll let this group know as soon as it's actually published. Joseph? A subset of that study we looked at to determine if a resuscitation first or an airway first approach to severe trauma with low GCS was better. So ATLS still recommends the ABC approach. Someone's in shock, altered mental status, consider placing an advanced airway. And we compared those groups, the patients who in the pre-blood era got an airway first and the patients in the post-blood era who got blood first. And we showed they were similarly sick on the scene. Next slide. In fact, the patients who got an airway first were actually sicker with a higher shock index. You can see in the next line below, same numbers, only 1% about in the circulation first group got intubated, whereas 100% of the others did. And the mortality in this group was even a wider spread. If you go to the next two slides, Joseph. Dramatically higher mortality in one patients who got an ABC approach, meaning what the paramedics in that era had in this agency available to them was an airway and saline. Those patients died a lot more often than those of similar injury pattern and severity who got blood first and then didn't have to be intubated. It's pretty interesting stuff. Next slide. So in this study that we're publishing, we'll show that implementation of this bundle, blood, TXA, and calcium, and again, we don't know exactly what the relative values of each of those components are. I believe blood's the most important. I believe in the adjuncts of TXA and calcium as well, and we probably should be implementing them, though be aware that that's controversial as to how much and when we give those other products. But the odds ratio, the risk of death, was dramatically lower to 0.2 compared to folks who didn't get blood. So this is good observational evidence. My friend Jeff Jarvis and the EMS Lighthouse podcast will not consider this a definitive study because it's not a randomized trial, but it's pretty good observational evidence that giving blood, especially in an urban environment with severe penetrating trauma and short transport times, can be effective and can save lives. Next. You can see here what we end up naming the dead zones. Where is care not being provided? It's in the interval between injury and 911 call, the interval between 911 call and arrival at the scene. And you heard in one of the stories, some lay folks ended up providing some hemorrhage control to the patient, the first patient we heard about, so that some care was given there. But then another dead zone, maybe our own EMS transport, where we're doing nothing effective for resuscitation until we get to the hospital. And we all know, if we work in an ED, that once you arrive at the ED, it's not like resuscitation begins magically the second they arrive. There's in this study, a 7 to 20 minute delay in the trauma bay before the first drop of blood is given. So to the extent we can push that into the field and get it all done in the field, as in this study, 2 units of pack cells, TXA, and calcium, we can actually begin care and effective resuscitation earlier. We can save lives. Next. And then we actually looked at the pediatric subset in this group as well. 13 kids in that 1.5 year period who were shot, sadly. And 3 of them were dead by the time the paramedics arrived on the scene. They were excluded. 1 was shot in the head. He was excluded from analysis, unlikely to survive. Therefore, 9 patients were included. They had a high shock index and a low systolic on the scene. They all got blood. Most of these kids got 2 units. I think the 8-year-old got a little less than that, but most of them got an adult dose of blood, calcium, and TXA. All survived a discharge. These kids with hypotension on the scene and at arrival have a predicted mortality of 50%. The study doesn't prove anything, but it's evidence showing us that we can actually make a difference in the kid I first described to you who died because we didn't effectively resuscitate her. And so we have the ability now, as we push blood and effective critical care out into the field, to save the lives of kids and adults. Next study. And I want to point out some of the data emerging out of Florida as well. And I think we are beginning to collect some good data elsewhere in the country, Virginia and elsewhere, where they're using a similar protocol, except they're using whole blood. I'm probably an advocate of that over pack cells, but if pack cells is what you have, then use it. They also give TXA, but not calcium. And they give it to kids 5 and older. Next slide. And they've shown, again, this is just an observational study, but in these patients, the same subset, this San Antonio study, the same subset we studied in New Orleans, it's patients who are not arrested on the scene, that the mortality after giving blood in the field is 10%, almost identical to what we found in New Orleans. So that's a dramatically lower percentage than you might expect for this severity of illness. And so I think we're beginning to develop data that are encouraging and that can move us toward all implementing blood programs in our EMS agencies to the extent that's possible. So Joseph, I'll stop there. And hopefully we can, in another episode, go into more depth in some of these studies.
Right.
Thank you.
Thank you, Mark. We're going to move into questions and answer. I'm going to drop the screen, but before I do, just to let you know, we'll be sending you a follow-up survey with information and resources that we've talked about today and additional studies will be directed. So with that, we're going to go to the Hollywood Squares. If you have a question, it's helpful for me if you raise your hand so I know we've got a bunch of people online, and then we'll call on you. You can unmute and ask your question. And while you're looking to raise your hand, one of the things throughout this presentation is, there's a difference in, we have a pretty heavy rollout in, not in urban areas. And I think one of the problems is the urban myth of we're so close to the hospital and we should just transport this patient and let the hospital deal with it. The issue there is most hospitals still have a process to go through to evaluate the patient, set them up to give blood, etc. There are some, I don't think they're published studies yet, but there's some studies ongoing to show what the delta of time is. And it's pretty significant. I mean, you wouldn't wait to defibrillate a patient until you got into the ER. With the right capabilities, you can actually get things rolling within 2 minutes and make a huge difference in the stability of that patient.
Joseph, I'll add on to just one point on to your point, which is we will also publish data showing that every minute in delay of blood delivery in ground EMS is going to result in a significant increase in mortality as well, for the very reason you mentioned. That care starts earlier, and the delay until the first drop of blood in this study will be about 20 minutes after they get to the trauma bay. That's not true everywhere, but things don't magically happen once you drop the patient off. Access, getting the blood ready, getting it given, those things are a dead zone of delay that we can blunt by giving blood earlier in the field.
Let me introduce, we'll put her on the spot, Randy Schaefer. Dr. Randy Schaefer is a lieutenant colonel retired from the U.S. Army. He is one of our subject matter experts and has helped to start a number of the pre-hospital delivery programs. Randy, anything you'd like to share?
Hey, good afternoon from Dallas-Fort Worth Airport. Thank you for allowing me to join. I've actually helped with some of the earlier programs get set up in North Carolina with Dave down in Onslow County. We're working on some national efforts to help support programs getting implemented. If you're not tracking the Pre-Hospital Blood Transfusion Initiative Coalition, we can send you information on that, where a group of pre-hospital advocates is working to come together to remove some of the barriers to implementation. So if you're thinking about starting a blood program, the wheel has been invented. We're just picking out spinners and whatever you want to go on your vehicle that fits your area. If you have a program and we're not tracking you, please drop it in the chat. We're getting ready to release some data on blood programs across the country. And I will give you a sneak peek that congratulations, North Carolina, you are #2 in the country behind Texas in terms of number of pre-hospital blood programs. So congratulations. Please let me know how I can help. And I've been unofficially adopted into the North Carolinian family based upon my barbecue choices. So as a Texan, that's good.
We'll let you stay. Thank you so much. Ben Smith, you've got your hand raised. You want to unmute?
Yeah, sure. I'll say, for people who don't know me, hey, Ben Smith, I'm the medical director for Air Care. One thing that, with all the discussion, I think is helpful, I think everyone here probably agrees that, yes, we should be giving blood in the field. I completely agree with that. I know the biggest challenge seems to be logistics, so I'm glad that's something that we're talking about here. I almost wonder if it might be helpful, but this could be a starting point as a group, to maybe have, I don't know, whether it's a survey or some sort of tracking how different places are tackling logistics. For example, where they're getting their blood from, if they're cycling it back before it expires, who they're doing that with. And then similar with like the trauma centers, what trauma centers are using whole blood versus RBCs versus, and same thing for our EMS systems. I think that might be helpful. To speak candidly, so we carry RBCs on our aircraft with Air Care at Air Life down in Robeson County. We have plasma and RBCs. I would love to go to whole blood at all those, but the logistical barriers of I don't have anywhere to send those units of whole blood to before they expire, plus finding the whole blood. So I think it might be helpful in the region to see how people are tackling those logistics. What are they carrying? Where do they get it from? Where do they send it to? Those sort of things might be helpful as we continue to make this wave get bigger and surge more.
Yeah.
Ben, I'm gonna
Great question.
Yeah, Ben, I'm right there with you. And on our radar screen of projects and in the repository is exactly those demographics that you were asking about. Randy came here to North Carolina a few months ago and we did a whirlwind tour, and she discovered very quickly that there are very clear and distinct model differences depending on where you're at, all of which are high functioning, but very different in just what you said. Turn back in time, logistics regarding tracking, everything else. And what we're finding is even though we are second to Texas, we are very diverse in our models and our delivery systems. So that is something that is on this grassroots group to figure out, one, as Randy is doing, who's got the blood, and then literally drill down and figure out how we're doing it so we can make that available to everyone. So again, when it comes time to start your program, it's totally there. Hey, I will share with you, True, the hospital that I work at Wilkes Medical Center does not have whole blood, but EMS does. So we've already run into situations just like what's been called before. We've called a county ambulance to come to the emergency department because we needed whole blood. So it's there, and there are those success stories that we will share when Jason Revis and I, when we highlight the Wilkes system in other counties such as Henderson County, Caldwell County, Burke County, McDowell County. These are all out there, the stuff that David has done. We want to make this out there, and we want to tell this story as Randy's trying to do, because we're doing cutting edge stuff. It's just nobody knows about it yet.
I would echo that. And similarly, you've seen one EMS system, you've seen one blood delivery system. There's so many variations. A majority of people are purchasing their blood outright. Some have relationships with hospital blood banks. We have a new tribe to add to our committee, which are the blood bank managers, and they'll be represented in our next segment that we do coming up after the first of the year. There's a lot of logistics involved, and there are different models, and there's new materials coming on board. Potentially in the next couple of years that could make some of the logistics easier. So yeah, it's an ongoing thing. And Ben, you representing the flight side, we know flight services are a predominant way that blood gets to a scene today, pretty universally. But if you look at our rural communities, and there's a nice map on our website, you'll get that web address, that needs to be updated. And we rely on Randy to give us the dots to find out who's doing what with blood. It's pretty diverse across the North Carolina landscape. Dr. Winslow.
Yeah, really great lectures, wonderful information. I definitely proponent of pre-hospital blood. One thing about the logistics, I have the opportunity to sit in all the trauma site survey visits in North Carolina when the trauma centers are getting re-credentialed. And there's been a few centers where you'll sit in and they're going over some of the pre-hospital care, and there'll be significant delay in scene times. And usually, well, not usually, but in some of those cases, they were due to waiting for a supervisor to bring blood to the scene, and which delayed, resulted in a delay in transport. Maybe that's worthwhile, maybe it's not, but I would caution, when you're doing logistics, there's a balance there between delaying transport, waiting for blood versus just going and maybe meeting the blood on the way to the hospital or just going straight to the hospital. So that's just something to consider about, how you're getting the blood. And I just caution you to be careful on long scene time delays if you're waiting for a supervisor or someone else to bring blood to the scene prior to transport, if that makes any sense.
Yeah, Chip, that's often one of the biggest pushbacks is the surgeons thinking we're going to delay by giving blood. And it can happen, as you point out. The study I presented to you, I didn't share, there was a 3-minute increase in time, total scene and transport time. However, that resulted in a significant reduction in mortality. So probably a short increase is fine, but delaying while waiting for the blood, maybe, as you point out, maybe not wise.
Yeah, Yeah, these are more like 15, 20-minute scene times and not like a 3-minute, but I think
Okay.
that's a small issue. It's just something to think about when you're planning.
Well, and I think that we're watching more mature programs across the U.S. who have adopted a pit crew model for their blood administration, where they've got defined roles for folks. You know, in the rural community, it may be blood given once a month or once every 4 months. So a lot has to do with how familiar people are with getting systems set up. There's no doubt you've got to rely on your previous history of traumas to know where blood logistically and geographically can be placed.
Yeah, and another good example, I know some counties which have to bypass smaller hospitals to go to their trauma centers, and they're
Right.
very uneasy about bypassing a trauma center, but that's why we've tried to work with them to start blood programs so they'll feel more comfortable about bypassing non-trauma centers to go to the hospital, to go to a regular trauma center, so which I think is a very good reason.
And I think it's worth mentioning, Tripp and I are, and others on this call are on the North Carolina trauma plan development, the next cut of the North ACS trauma plan for North Carolina. And I think horizon issues like blood administration, maybe ultrasound, maybe some other features of skills need to be built in for what will be a 20-year plan for trauma services in North Carolina. So if not now, certainly looking out at a strategic plan of 3 to 5 years to add these features. Other questions?
This is Jeff Williams.
Yes, sir. Go ahead.
Yeah, this is Jeff Williams. Can you hear me? I'm sorry.
Yeah, we got you.
I apologize. I'm en route somewhere and can't figure out how to raise my hand. I just wanted to chime in right after Ben and Dr. Winslow spoke. I would love also more information on sort of the measurement of utilization. And I guess my question for folks around the state, or maybe some of the earlier presenters of their programs here, would be how are you measuring utilization in terms of either underutilization or even overutilization of, obviously the precious resource. The context for us is that, and I apologize for those that I don't know, I'm the deputy medical director in Wake County. In our preliminary conversations with the trauma center, that has been a prominent sort of discussion point in terms of, you guys are a big system, what would the deployment look like, and how could you be sure that we're not, giving blood to people who don't necessarily need it, right? And or giving blood sort of not per protocol. And obviously Dr. Winslow is aware, but Dr. Winslow and his colleagues just actually published a really interesting study on tranexamic acid that suggested that around North Carolina, sometimes tranexamic acid is overutilized. And obviously those are similar populations. So that's a question that we're dealing with here. And sort of, we want to have a kind of a QA plan, in place, obviously, even before we start. And I would love more information from either across the state or nationally about how people are measuring that.
That's a great point. I see James Hood is on, who's our North Carolina data analyst out of the Office of EMS. One of my questions would be globally, if we could go back 3 years and look at vital sign parameters and trauma related patients, what's the population to be served in general? Just doing a quick data search for patients who by vital sign would meet criteria. Of the mature programs that are out there across the U.S., there was a question in the chat about age range. A lot of the programs have started out with call before you do, call medical control before you administer blood, to call based on age, and most have universally dropped it to less than 5 years of age to call. So making it more universally available. Christina, you raised your hand before Tripp. I'll let you go first.
Yeah, just kind of in response to Jeff's question, all of the counties and air care services that partner with Atrium Health Wake Forest Baptist send their chart records for patient administrations of blood products to me. I review them for documentation for regulatory purposes, and then they all get reviewed by Dr. Fide. I don't know if you're familiar with Dr. Fide. He's our board certified transfusion medicine medical director. So he's going to look for appropriateness of transfusion in every single pre-hospital blood transfusion that gets done from our blood supply.
And Christina, who are you and what do you do?
I'm the blood bank manager at Atrium Health Wake Forest Baptist. So we support Wilkes County and the air care crews here, and then hopefully soon a couple other counties.
Thank you.
I can
can say
add
from the
one
medical
thing.
director side, Dale,
Super useful. I apologize, guys. I'm still mobile. That is super useful information. And I will say that if anybody who does that sort of thing, either on the blood bank side or medical director side, those data, if they're publishable or shareable or we put in a presentation, that's really powerful information for folks who are unconvinced that EMS can do this successfully.
Jeff, I'll add, this is why we're so focused on the repository for information, to get that out for folks just like yourself, to have that piece of information you can take back to administrators or other people to make this work. The success stories of building those relationships, we are truly in our infancy. Sometimes we don't know what we don't know just yet, and it's trying to figure this out and get the appropriate data out to those who need it. So excellent request, and it's something that is on our radar screen to make happen.
Rip, I'll let you go next.
I mean, really, I'm just more or less agreeing with Christina. I think one of the most important things is develop a relationship with your local trauma center through your RAC, because they can give you feedback on what happened to that patient, and you can work with your RAC to find out, what changes you need to make. And building those relationships will probably increase your ability to do new and different things, because, one thing we try to push through trauma is a team sport. And the more you build those relationships and get that feedback, the more you can be able to do.
Randy?
So I was going to offer that in San Antonio, when we rolled out the program, of course, we QA'd everybody that got it to make sure that there was not overuse. What was interesting is we wanted to see if we had blind spots, patients that may have benefited from getting it but did not receive it, and why didn't they receive it? So without going into the total details of it, that was actually my doctoral project, was to review all the cases of missed opportunities and dig into why those happened. Some of it was a clinical miss, some were operational issues, some of it was equipment unfamiliarity, but we actually had more cases of missed opportunities for transfusion than we ever did over transfusion of patients, if that helps. So when you're building your QA programs, look at those who got it, but also build in some mechanisms to keep an eye to make sure that you aren't missing patients who would have benefited.
Thank you for that. Cam, I'm going to put you on the spot here in a second. We have a number of notable guests within our ranks, one of which is Gam, who is the chief of the office at NHTSA. They have a number of programs. DOT in general has a number of programs at Project Zero, which I think probably one of the things is their grant dollars available for communities to work on trauma care post-event. Glad to have you. Does this conversation make sense to you? We can't hear you. Government issued microphones. Nope.
Careful what you say about government issued microphones.
John, I was coming to you next. Well, and while we wait for Gam to get audio, John Cromer also heads up a national group. John, you want to tell us a little bit about what's going on at your level?
Well, I'm happy to, but I want to first clarify. I'm working with a whole bunch of folks, so I'm not heading up something at all. I'm fortunate to work with a large number of folks, as Randy alluded to. Several months ago, we developed a pre-hospital blood transfusion coalition. And I will compliment you all in North Carolina by bringing your group together and reflect that this national coalition, yep, you're live now, Gim. Reflect that this national coalition really is trying to accomplish the same things on a national level that you are working on in North Carolina. And I'll highlight particularly two things. One is the scope of practice issue, because as you all know, scope of practice is defined at the state level, although we have the national scope of practice model. That is a model and a guideline that can be used by the states, but it's up to every state office of EMS to specifically define the scope of practice. There are some states like North Carolina that allow it. There are some states like Colorado who has recently implemented a waiver process that folks can go through, and other states that are still working on the issue. So we're trying to gather the background information to find out where the landscape really is right now, and what we can do to learn from North Carolina and Colorado and other states to help states that need to modify their scope of practice. The other very large focus area is on reimbursement, because as you all know, there currently is no reimbursement available for pre-hospital blood administration, with the exception of hospital-based programs that can potentially roll it into the hospital expenses. We're looking at issues of community education and outreach. We're looking at strategic planning issues and how that may fold into some of the activities that the federal government is looking at currently, research and things like that. So the goal of this coalition really is to serve to help communication and collaboration. As many folks say, we'll get information in, best practices, model protocols that can be ripped off and duplicated, was already alluded to in your discussion. So we currently have about 30 national EMS organizations that are participating, 70 other individuals. If folks are, and the North Carolina Coalition is one of those participating organizations. Joseph is representing you all on the National Coalition. But if as an agency or an individual, you'd like to learn more about the coalition or participate in any of its activities, please feel free to, I'll put my email address in the chat. Feel free to email me. We will add you to the coalition. Randy is focusing on the reimbursement issues. So any of you that are great at working with private insurers or CMS or state Medicaid services, let us know, and Randy will draw you into that activity. So welcome any interest that folks have. Thanks. I appreciate the opportunity to chat.
Thank you, John.
And thanks for letting me listen in. This has been a great discussion.
Hey, we believe in misery and joy's company. Rolling over to our federal partner.
Can you hear me now?
We can.
Okay, took me a minute, and enjoyed also hearing from my former boss John there as well. So I think I just had I appreciate the opportunity to just listen in on this conversation and learn more about how agencies are implementing blood transfusion programs. I think you had a question about grant opportunities through the Department of Transportation. As we've mentioned on previous calls at NEMSAC and FICMS, the bipartisan infrastructure law did significantly increase highway safety funding across the board at DOT by roughly 50%. So our state highway safety grant programs increased by 50%. And there were also several new grant programs created, including the Safe Streets and Roads for All grant program, which is a grant program that goes directly to local agencies to improve highway safety. The FY23 round 2 awards for that program actually just got announced this morning and are posted online. One of the awardees is actually does have a strong post-crash care focus, and this is all public information as of a few hours ago, and that's the Town of Colony EMS agency in New York State, where they received a sizable award to improve post-crash care. So when I say post-crash care, that's our terminology under what's called the safe system approach for really improving trauma care to patients in the field, as well as clinician safety on the roadways. The awards that got announced this morning, I did mention, the sizable award in New York. However, what we are encouraging all folks to do is there are what are called planning grants that go out through SS4A to localities. And the majority of those have been awarded to local departments of transportation. And the reason why we want to make sure that EMS agencies are aware of these is because those local DOTs have received a grant to put together a comprehensive highway safety plan, which should include post-crash care as one of its pillars. So we're encouraging local EMS agencies, if you see your locality on that list, make sure that you reach out to the awardee and get involved in that planning process, because ultimately those localities will bring back that plan as part of their application for implementation grant funding under SS4A. And I'll drop a link to everyone if you want to learn more about SS4A. We're also planning a webinar in mid-January. We're still organizing it, but we'll be getting the word out through our through ems.gov, a webinar to focus on SS4A, probably around the middle of January, around January 16th. We're just finalizing the time. So we're really trying to connect programs like this with some funding opportunities at the federal level.
I'll repeat that. Thank you for being here. I appreciate you participating. Appreciate the update. Anyone else? Questions or comments, or do I have to call on people? I appreciate you guys sticking around. We build this as an hour-ish. And we have some other partners nearby. This, just to give you some background, this is actually a task force of the North Carolina chapter of National Association of EMS Physicians. So if you're interested in being part of that group, part of that task force, I put my email in the chat. Just drop me a note to add you. We have a base camp that we're tracking information with. And what started out as a North Carolina project actually has representation from Maryland all the way down to Florida, all states in between, because everyone needs help getting these things off the ground. Certainly there's an issue of cost and planning logistics. And then what are you doing? And where is it happening? It's really important, I think, from Randy's perspective and from John's perspective, that we be able to map out the pins in the map. And oftentimes we don't know. Because in North Carolina, you don't have to file anything special to give blood. You update your protocol. So tracking where things are happening is important. And we'll try to keep you up to date. Our goal is to do about 3 more of these. If you like this one, we'll follow up with a questionnaire asking, did you like it, in the format. But to address things, especially like in rural communities, funding opportunities, we have some pretty major foundations within the state that I think would attach themselves to an improvement project. David Long, my friend from the north. You're unmuted, but we can't hear you. David? All right, we'll pop a couple flares.
Joe,
David, if you,
while he,
oh, go ahead.
I'm sorry, Joe.
Go ahead.
While he's working on coming off mute, I just want to really put a pin in what you just said about sharing the information. Because as folks alluded to earlier, every system is going to be unique in terms of its operational capabilities, its operational perspective, its ability to get whole blood, plasma, packed cells, you name it. So the more, and this is from the National Coalition perspective, the more information we can learn and be able to share with everybody else, giving credit to North Carolina and the appropriate programs, the more it helps everybody. So yeah, being able to gather as much information as possible is just wonderful.
And Joseph, just speaking from a state perspective, whatever assistance we can get to programs who want to work on these or institute a blood program, or we have the regional specialists available, I'm available, whatever you need, because I really do think this is important. And so, and it's a way to save lives. And I appreciate you putting this together. And I really appreciate, the folks participation from outside the state and from the federal level. And John, we really appreciate it. And thanks for your work and everyone else's work on this.
Yeah. And I will mention the timing is right. We're on the bleeding edge. That's probably not the best term, but it is what it is. The National Trauma Registry components, ESO is modifying the trauma registry based on some participants in Florida who have integrated the questionnaire that's being used down in Tulane into the trauma registry. So we'll have more universal collection of similar data on specifically trauma patients. Of course, it doesn't address GI and it doesn't address OB-related administrations, but anything's better than nothing. And total tracking of outcome of patient is really important. So I think you're going to find within the year some opportunities, especially for your trauma coordinators, to increase exchange of data. John, follow up.
Just a quick clarification that I meant to make when we were talking about this, particularly since I talked before GAM. The national coalition that we're talking about is a civilian thing. It is not a federal NHTSA or any other federally sponsored agency. So just wanted to make sure that there wasn't any confusion about that.
Certainly. And you guys have a nice website, and your project plan sort of is pretty explanatory. Other comments?
Joseph, can you hear me now?
Yes, sir. David, go ahead.
Sorry about that. So just as far as your friends from the north, so one thing that we've done uniquely different is I manage a regional EMS council, which means I have 10 jurisdictions, so 6 cities, 4 counties, and we're blessed. I've got 4 designated trauma centers, in my region. So I don't, it's not a challenge for me necessarily to get to a trauma center. So certainly blessed by that. But by doing it from a regional perspective, we basically established a standard that a regional protocol is used. I acquired all the equipment and provided it to the EMS agencies. I have a contract with a blood supplier. So I'm able to supply the blood, for them to use. And, when you talk about the, the rip-off component, I know that Dr. Duchesne speaks of that very passionately. So we have watched programs, develop from San Antonio across. I certainly, in the beginning, I'm trying to remember down south for you guys. I can't remember Nestor's agency affiliation, but for a group, for a regional EMS delivery system in North Carolina that basically has a community hospital with no trauma center access and how they successfully managed the program down there were a great help to us in implementing. So when you talk about that, how we can learn from one another and what we can glean from that, right? We are following in the footsteps of New Orleans. So been in conversation with Dr. Peel in regards to what we're doing, but our advanced resuscitated care bundle is going to be a little bit different than theirs. We're doing 2 grams of TXA bolus versus a unit of whole blood and a unit of calcium gluconate. So we're changing the calcium, concentration. Obviously, calcium gluconate's 10%, elemental calcium compared to the 30% you get with calcium chloride. But we believe it's safer for our patients, especially through the vascular access that we typically have in a pre-hospital arena versus what the hospitals do. In our research, we were able to see that hospitals only administered calcium chloride through central line. So because of that safety piece, we chose to go that direction. So we're working closely with Louisiana and Alabama and doing an IRB on what serum and ionized calcium levels are on our trauma patients. We're looking at 2 groups, those that receive blood product versus those that don't. The other thing we're paying attention to is that, like New Orleans, who's using component therapy, they're exposing their patients to more donor sources than we are by using a single unit of whole blood. So another thing that we're trying to pay attention to when we do this. So thanks for letting me jump on and listen to some of the things you guys are doing down there, knowing that we are still kind of lockstep with y'all. So if there's anything that we can do to help you, happy to do that.
Thank you, David. From what Commonwealth are you from? Where are you?
So I'm the Commonwealth of Virginia. So I'm in the Tidewater region, which is really sitting on North Carolina. So I have access to Currituck County, Pasquotank County, Camden County are my closest. So I've done some consultation with DARE and their MedOp services when we started our blood program and provided them all of our information to use down there. So.
Glad to have you as a partner. There was a point in time where you were part of North Carolina, but that's a whole other discussion.
Sure.
It's an old.
Hey, over a bourbon anytime, no problem.
I just saw a request in chat for you to share your email address, if you would, David, for follow up. And Dr. Winslow says it was Robeson County. Is that correct, Trip?
That is correct.
Probably
Yep.
Nestor Rivera. Yeah.
Yep.
Probably Nestor Rivera.
Yep. He's a good dude. He's a good dude.
I think Currituck County was also looking at a grant to use drones to deliver blood. I don't think that went anywhere, but they were looking at that.
Well, my good friends in the far north, New York, are doing the same thing. So it'll be interesting to compare how all this works out. Speaking of other states, Aaron Dix, you still with us?
Yes, sir.
Mr. Dix hails just south of us in the grand state of South Carolina. Would you like to tell us a little bit about your program?
Sure. We've been running about 3 years. We're a hospital-based EMS system that does 911 critical care interfacility. We use 2 units of PRBC, 2 units of FFP in each of the coolers. There's a significant shortage of whole blood in our area. We're at about 300 administrations. About 55% are trauma, and then the rest are medical. About 5% are we consider specialty, right? Where do they fall in? We had some OB, dialysis, shunt ruptures, things like that. But we had a great case of a 7-year-old shot in the chest in a rural area that was published in PEC. She actually got 2 full blood coolers on the way to the hospital, 68 miles from a trauma center. We've delivered a massive blood transfusion to the field twice, used it once. And we've had 8 cases where we've had to use two coolers for a single patient. All of those were entrapments where they got more than 1 cooler while we were trying to extricate them. I firmly believe, just from the data that we show, which is primarily, lack of a better term, anecdotal. We've done 2 studies. One of them was a research study that just looked at warming blood. We use The Credo cooler, because we want to be mobile, about half of them we're intercepting with other agencies. So we need to be able to grab our cooler and jump in the back. To earlier points, we do not stop seeing times. We will only intercept. So if what we try to do is simultaneous dispatch. So if it meets certain criteria, we're sending the blood cooler with them. So if they need to be, they're canceled. If not, we jump in the back of the truck. We just grab a cooler, jump in the back. But you know, we have everything from rural areas to kind of our urban area. But we track our scene times. We haven't seen an increase in scene times. We've had no transfusion reactions. Out of those 300, maybe 5 of them were pulled as questionable on whether they should have been administered. And in those cases, they were just really complex patients that were probably septic with also a GI bleed. So they were really on that fence where they had a shock index greater than 0.9. They were tachycardic, but they were also 70 years old with multiple comorbidities. And I think in hindsight, maybe probably some fluid should have been given first. Not sure if that meets what you were looking for, Joe, but
yeah, no,
happy to help any way you guys want.
We want to be,
and we use the
neighbors.
quantum warmer. Yeah, we use the quantum warmer.
Okay.
So we warm all of our blood.
I appreciate that. Anyone else comments before we close out? Seeing no one panicking to drop their mute. Thank you all very much for today. Thank you to my presenters. Appreciate it. This technically should be recorded. It will be posted. We've got a follow-up survey coming to you guys proper. Those who want to be put on the base camp, I'll read through the chat and get you added for that. And I look forward to the partnership going forward. It's going to be an interesting year ahead. Thank you so much and have good holidays ahead. Thank you.